Hello friends, Dr. Kofi here and welcome to my YouTube channel, TutorMed, where everything medicine is simplified. In today's video, we will look at 5 tips for writing excellent case summaries for wardrounds in internal medicine. This style we will discuss is based on the knowledge I acquired during my training as an intern doctor under various superiors. And so we will explain the 5 tips and give a complete case summary example. To all my subscribers, I want to say a very big thank you for your support. If you are new here and are yet to subscribe, kindly support us by doing that and hit the notification bell to get notified when new videos are uploaded. Please do not forget to like and share this video and leave your thoughts in the comment section. Alright friends, please grab your notepads and let's quickly get started. Good. And so this is how a major ward rounds look like. There is a patient who is under the care of the entire team, but one doctor is in charge of that patient's condition, and she will be the presenter for that clinical case. And so she presents the case to the team, and one of the team members is in charge of the ward rounds. That is the senior most member of the team and is usually a consultant physician. And so just to create some humor before we delve into the tips, the quality of our case summaries as junior colleagues and the personality or temperament of the consultant in charge will determine if we will have ward rounds or war rounds. Well, that was just by the way, and so it is important we know the tips for writing excellent case summaries. I am not saying that these are 100% right, but at least these tips will guide you to write good case summaries. Now we need to establish some general principles of a good case summary. A good case summary is not a repetition of the entire history and physical examination findings. It summarizes the relevant information necessary for diagnosis and management. Another hallmark of a good case summary is that it gives a diagnosis or clinical report which is apparent just by looking at the patient and his surroundings. Now, most of our superiors are just so excellent and experienced that just by looking at the patient and his surroundings, they are able to tell the most probable diagnosis even before we speak, and so the diagnosis we give should be almost evident just by looking at the patient. Imagine giving a diagnosis of gastritis when our patient looks cachectic and is on supplemental oxygen. You would agree with me that we are setting the stage for war rounds, isn't it? Very good. Another feature of a good case summary is that it reports relevant investigations in a diagnostic way. For example, instead of saying the full blood count shows an HB of 9.9, MCV of 82, MCHC of 33, platelet count of 238, and so on, a good case summary would say the FBC shows moderate normocytic normochromic anemia, an HB of 9.9 grams per deciliter, with a normal platelet and white cell count. If your superior wishes to know the red cell indices, he or she will ask you for them. But please learn how to report investigations in a diagnostic way because you are presenting a case summary. Alright friends, please do not forget to like and share this video and subscribe to our channel if you have not done that yet. And so let's see the tips for writing excellent or good case summaries. Tip number 1 or step number 1, please learn how to write opening statements. Now the opening statement is made up of the patient's name, the patient's age, and the patient's sex, and then the number of days on admission, and whether the patient is known to have any chronic medical condition prior to this current admission. Now, the third point is relevant in so many ways, and one of them is, for example, if we are presenting on a patient who has ascites, jaundice, and pedal edema, and we mention in the opening statement that he is known to have chronic hepatitis B infection diagnosed, say, 4 years ago, and is not on any medications, then the clinical picture becomes clear that this is likely a chronic liver disease from a chronic hepatitis B infection. And so an example of an opening statement will be, this is 65-year-old male, Mr. Joe Sapon, day 4 on admission, known to have hypertension diagnosed 3 years ago, but is not compliant on his medication. And so here we see the patient's age, the patient's name, the patient's sex, his number of days on admission, and then the fact that he has chronic hypertension or hypertension diagnosed 3 years ago and is not compliant on medications. And so the opening statement sort of gives us a general background of the patient before he was admitted. Now, after writing the opening statement, the next step or second step is to give a complete diagnosis. What are you currently managing the patient for? A complete diagnosis features primary diagnosis or the primary diagnosis with complications, if any. I'll note that there may be more than one diagnosis for the patient. As an example, a complete diagnosis can be like this. After we've mentioned the opening statement, then we say we are currently managing him for end-stage renal disease, secondary to diabetic nephropathy, complicated by moderate normocytic normochromic anemia. And so here you see that the primary condition is diabetic nephropathy, which has resulted in end-stage renal disease, and the end-stage renal disease has been complicated by anemia. Then let's take a second example. We are currently managing her for congestive cardiac failure, secondary to ischemic cardiomyopathy, and complicated by a pre-renal AKI. And so this is also a complete diagnosis. The patient had an ischemic heart disease, maybe a multi-vessel disease some time back, and it has led to congestive cardiac failure. And this whole condition has been complicated by a pre-renal AKI because of a decreased renal perfusion. And so your opening statement, and then you tell us the diagnosis, which should be a complete one. Right after giving the opening statement and your complete diagnosis, the third step, or tip number 3, is to defend the diagnosis you've given. Now, the diagnosis defense is by a focused clinical history, relevant physical exam, and investigations. And so, for the defense by clinical history, you give a brief and comprehensive presenting complaints and history of presenting complaints. And so, for example, for the end-stage renal disease secondary to diabetic nephropathy with the anemia complication we gave for our previous slide, or in our previous slide, the defense can be like this. He was in his usual state of health until 4 months prior to presentation, when he noticed a recurrent early morning facial puffiness and a 2-month history of progressively worsening bilateral leg swelling. He visited the OPD of a peripheral facility, from where he was referred here for further evaluation and expert management. Then you come to your on-direct questioning, and here you state important positives, which points to the diagnosis and the complications you've listed, and the negatives, which refutes other differential diagnoses. And so questions like frothy urine can be asked, and if present may point to proteinuria from the CKD. Questions like anorexia, malaise can also be asked because they are non-specific symptoms for CKD. we can ask questions to establish the anemia complication like palpitations, dizziness, easy fatigability. Again, questions may be asked looking for other end-stage renal disease complications like epigastric pain for uremic gastritis, pleuritic chest pain for uremic pericarditis, etc. But the point here is that your brief history should reflect the diagnosis given. And more importantly, the history you are given or the diagnosis you are given should be apparent when the patient is just looked at by your superior. And so, still on the diagnosis defense, from the history, you move to the physical examination findings, and here you begin with the vital signs of the patient at presentation. And so the patient's temperature, the patient's pulse, the patient's oxygen saturation on room air. Now, one of the clues here is that you summarize non-diagnostic or normal examination findings, particularly when that aspect of the examination is not related to your diagnosis. Take, for example, a stroke patient. For the abdominal exam, it is likely to be normal, and if normal, you don't have to go through the presentation by saying the abdomen was full, soft, non-tender, etc. Summarizing that the abdominal exam was clinically unremarkable is enough. Then the second clue is that you mention diagnostic exam findings, whether present or absent. An example here is if you are presenting a case of heart failure. The cardiovascular exam findings have to be thorough, and in fact, after mentioning the general exam findings like the patient looks unwell, not pale, not jaundice, etc., the cardiovascular exam has to feature next. And then you mention signs which are diagnostic for heart failure, including raised JVP, apex beat displaced to see the left safe intercostal space anterior axillary line, tender hepatomegaly, and then fine bibasal inspiratory crepitations, etc. So the point here is that if your patient has heart failure, after giving a brief general examination findings, you move to the system which diagnoses the heart failure. You don't present on the respiratory system, the abdominal system, and then come to the system which is needed to diagnose heart failure. In other words, when presenting the findings of physical exam, the reportage should be focused at diagnosing the patient. Still on diagnosis defense, after history and exam, the next is defense by investigations. And here, the clue is that you mention diagnostic labs first and report your findings, like I said, in a diagnostic way. What I mean by this is that, assuming you are presenting a case of stroke, you've done well to defend your diagnosis by history and physical exam. When it comes to investigations done for the patient, do you think it will be wise to mention the full blood count first? No, I don't think so. The first investigation our superiors may want to hear is a plain head CT scan. That is defending your diagnosis. And so mentioning the full blood count first kinds of waste time. Let's take CKD as another example. We are presenting a case of CKD. The first investigation should be a blood urea, electrolytes, and creatinine, because we need an elevated creatinine to see whether the patient has an impaired renal function or not. Then, a urine RA should be done for evidence of renal damage, including proteinuria, hematuria, or sometimes broad casts can indicate an advanced CKD. And then, another investigation that is worth mentioning is an abdominal ultrasound scan. What are you looking for? You are looking for sonographic evidence of CKD, like a reduced kidney size, an echogenic kidney, etc., before you mention other investigations like full blood count. Now, It is understandable that sometimes some labs are requested by some colleagues before we see the patients. A lab like blood film for malaria parasites is sometimes requested by the first clinician who sees a patient. Please, if this is not relevant to the diagnosis, do not mention it at all, although it has been requested for the patient, because it may put your superior off. I mean, think about it. Why would you mention blood film comment for malaria parasites when you are saying your patient has congestive cardiac failure? What has BF for MPs got to do with heart failure? And so you see that mentioning BF for MPs is kind of setting the stage for World War III. Very good. And so after defending the diagnosis, the next tip, or the fourth step, is to come to the management of the patient's condition. What has been done for the patient since admission, and the progress of management. And so for the management, you mention the medications the patient has been on and the duration they've been on those medications. And for the medications, you mention the route of administration, whether IV, IM, subcut, oral, the name of the medication, say ceftriaxone. Then you come to the dose of the medication, say 2 grams, and then the dosing, say daily, and then you add the duration. And so as an example, you say the patient is on IV ceftriaxone 2 grams daily for 4 days. Then other non-pharmacological interventions should be mentioned if any has been instituted for the patient, like physiotherapy, especially for stroke patients, when it was started, and then the number of sessions the patient has had that intervention or physiotherapy. Then tube thoracostomy, you want to mention that, and mention things like how many days we have been dressing the wound, and then the amount and nature of fluid that is drained, and then whether the tube is functional or not. All these have to be mentioned. After mentioning the management of the condition, then you come to tip number 5, or the next step. You tell the current state and clinical problems of the patient. Sometimes, for some superiors, we need to justify if the patient needs admission still or needs to be discharged. And then while telling the current state and the clinical problems of the patient, we need to include the patient's vitals, especially if the vitals at presentation was abnormal. We need to compare. For example, you say SpO2 at presentation was 90 on room air, and now it is 98 on room air. Very well, friends, please do not forget to like and share this video and subscribe to our channel if you have not done that yet. Now let's get to our second aspect of this presentation, and here we will take a sample case summary template or presentation on a patient with decompensated liver cirrhosis. And so let's begin the case presentation. This is admission day 4 of 48-year-old man, Mr. AK, known to have chronic hepatitis B infection, diagnosed 4 years ago, but is not on any medications. Currently, we are managing him for decompensated liver cirrhosis secondary to chronic hepatitis B infection and complicated by grade 2 hepatic encephalopathy precipitated by upper GI variceal bleeding with moderate anemia. And the second complication is moderate ascites. He presented with a month's history of progressive abdominal distension and a day's history of melena associated with palpitations, easy fatigability, and dyspnea. There is a history of jaundice, reversed sleep pattern, and bilateral leg swelling. However, there was no history of chronic or recent alcohol abuse, hematemesis, constipation, fever, or abdominal pain. Now, here you can see that the history I have given explains almost everything in the complete diagnosis I gave earlier on. The fact that he presented with a month's history of progressive abdominal distension and a day's history of melena makes liver pathology likely. It could be that he has ascites from a liver cirrhosis, which has been complicated by upper GI bleeding, which is manifesting as melena. And then we mentioned that it was associated with palpitations, easy fatigability, and dyspnea. And these are symptoms of anemia. And so the upper GI bleeding with anemia has been justified here. The fact that there is a history of jaundice also points to the fact that it could be a chronic liver disease. The reverse sleep pattern I asked here, which was positive, shows that there is hepatic encephalopathy. And then this is probably precipitated by the GI bleeding. Then we asked about bilateral leg swelling, which also supports the liver condition. Then we asked about a history of a chronic alcohol abuse. We wanted to rule out the fact that his cirrhosis is not from alcohol abuse. And we asked of a recent alcohol abuse, which was negative. Recent alcohol abuse can also precipitate encephalopathy. Then hematemesis also speaks for chronic liver disease, upper GI bleeding, which he didn't have. I asked about constipation because constipation can precipitate hepatic encephalopathy. I asked for fever and abdominal pain because I was looking for a possible spontaneous bacterial peritonitis. And so you see that the brief history makes the diagnosis I've given earlier evident. At presentation, his vitals were normal. He looked chronically unwell, was not in respiratory distress. The saturation on room air was 96%. He was moderately pale and icteric with satisfactory hydration. There was hysteresis. There were no other peripheral signs or stigmata of chronic liver disease. The abdomen was distended. No caput medusae. It wasn't tender. The liver was not palpable, but had a span of 5 centimeters in the right mid-clavicular line. The spleen was not palpable. There was shifting dullness. The bowel sounds were present and normal. And so here you see that I mentioned the moderately pale and icteric. The moderately pale would also speak for the anemia. And then we mentioned hysteresis. The fact that there is hysteresis gives hepatic encephalopathy grade 2 up. Then we mentioned that he had no peripheral stigmata of chronic liver disease. So we've summarized the fact that there was no pulmonary erythema, no spider nevi, Dupuytren's contracture, etc. Then you realize that after giving a brief general examination, I moved to the part of the exam which really diagnoses or supports my diagnosis, which is the abdominal examination. The fact that the liver was not palpable but had a span of 5 cm supports cirrhosis. The fact that there was shifting dullness supports the moderate ascites. Now, because I didn't find anything significantly abnormal on the rest of the examination. I say the cardiovascular, respiratory, and neurological exam were clinically unremarkable. Investigations done so far. The liver panel, or LFT, shows mildly deranged enzymes in a chronic hepatocellular derangement pattern. In other words, there was transaminitis in the hepatocellular derangement pattern. So here you can choose to mention the enzymes which were deranged, and then after that you interpret it this way. Then there was hypoalbuminemia of 2 grams per deciliter. The lower limit is 3.5 grams per deciliter. And there was conjugated hyperbilirubinemia. The Derity ratio was 1.2. And so here you realize that instead of seeing the enzymes with their values raw like that, we gave a diagnostic interpretation for the LFT. And please, if you are not familiar with the LFT interpretation, kindly look for our video on liver function test interpretation. We've made a concise lecture on that. The abdominal scan done shows evidence of cirrhosis and moderate free intraperitoneal fluid. There is no evidence of hepatoma. The INR was 2, giving a Child-Pugh score of 8, which is class B cirrhosis. And so here you realize that we gave investigations which were more diagnostic or supported our diagnosis we've given more than the other sort of irrelevant investigations. Then we say that the hepatitis B surface antigen was positive. Hepatitis C and retro screen were negative. The full blood count shows severe microcytic hypochromic anemia with an HB of 6 grams per deciliter, and then normal white cell count and platelet count. Alpha fetoprotein levels done was normal. There was normal blood urea electrolytes and creatinine. We are waiting results of diagnostic paracentesis, and he is scheduled for upper GI endoscopy tomorrow. And so for his management, 2 units of blood was given, and his current HB is 8.7 grams per deciliter. Then we gave IV octreotide, 50 micrograms stat, and then 25 micrograms hourly via continuous perfusion. Then we are giving syrup lactulose, 30 ml TDS, and he's done that for 4 days. And we monitor his stool till he passes 2 to 3 semi-form stools. We also monitor the stool for the color to see if the upper GI bleeding is resolving, and currently the color seems better. Now, when a patient is in hepatic encephalopathy, diuretics are generally contraindicated, and so in this patient we won't give the tab furosemide and tab spironolactone, although he has ascites. I'm not saying you mentioned this in the case summary, but I'm just pointing out the fact that I didn't mention tab spironolactone and then furosemide because the patient is in encephalopathy. Giving these drugs might lead to further fluid and electrolyte imbalance, which might further worsen the encephalopathy. He is also on tab metronidazole, 400 milligrams TDS. We are doing salt restriction for his ascites, and we are doing daily weighing. The daily weight loss has been between 0.5 to 1 kilograms per day. The admission weight was 76 kilograms and is now 73 kilograms. He's on IV ceftriaxone 2 grams daily for 4 days. He's done for 4 days. Tab tenofovir 300 milligrams daily. He's done it for 4 days. He's on IV dextrose 500 mils QID. He's also on oral glucose 50 grams QID, and we are doing RBS monitoring 4 hourly. Currently, he has no complaints today. His vitals are a temperature of 36.5 degrees Celsius, a BP of 100/60 millimeters of mercury, a pulse of 92 beats per minute, and then an RBS of 7.8 millimoles per liter. He is moderately pale and mildly icteric. His current clinical problems are grade 2 hepatic encephalopathy, moderate anemia, and then GI bleeding, which is improving. And so you end your clinical case this way. And if there are any lapses in your case presentation, the consultant physician in charge will point them out and will teach us how they should be next time. For example, in this case, the endoscopy was delayed. The endoscopy should have been done immediately when the patient was stable and the Rockwell score calculated. And so it was an error that the patient was scheduled for endoscopy later. The endoscopy could have been done so that banding would be instituted to stop the bleeding. And so some of these things will be pointed out by the consultant physician. But this is a template or a case summary example I gave with those pitfalls. And so thank you for watching, and please do not forget to like and share the video and subscribe to our channel if you have not done that yet. Bye.